I get often asked, do you think AI is going to replace doctors? And I say AI is not going to replace radiologists, but radiologists that do not embrace AI will be replaced. What I think is really important for your students and future students is this human-computer interface. So what are the right prompts to get me the right information? How do I use these very powerful tools in a way that promotes care and does not exacerbate bias? And do I understand how these models were made and where, when I should use them? Now, I don't think medical students need to know how to code, but I think they certainly need to know how to interact.
Today's PSA features Dr. David Feinberg, chairman at Oracle Health. Following a period of significant growth driven by strategic acquisitions, Oracle Health has established itself as a prominent player in the industry. My name is Dr. James Hildreth, and you're listening to Public Service Announcement. In this episode, Dr. Feinberg shares his enthusiasm for the future, highlighting advancements that could transform patient care and reshape the healthcare landscape. We address skepticism surrounding AI in healthcare and evaluate the current state of the industry. As a technology leader, Dr. Feinberg discusses how technology can be leveraged to serve underserved communities while overcoming challenges to ensure equitable access. To learn more about this show, or to learn more about Meharry Medical College, visit www.mmc.edu. Dr. Feinberg, David, can you just tell us about your background and what you're doing currently, please, sir?
Yeah, well, first of all, it's great to be with you and looking forward to our continued work together. So my background is I'm a child and adolescent psychiatrist. I spent 25 years at UCLA. The beginning of my career was kind of typical academic child psychiatry. And then the second half at UCLA, I had the opportunity to lead the health system. So the UCLA Medical Center and our physician group. I then transferred to a place in rural Pennsylvania called Geisinger, where I had the opportunity to lead that integrated delivery system that's really well known for innovation. From Geisinger, moved to Google and led Google Health pre-pandemic and during the pandemic. And then a few years ago, had the opportunity to move again, this time to Kansas City, to be the chief executive of Cerner. Shortly after I got there, Oracle reached out to buy us. That process took like a year. That was about 2 years ago. And I stayed on in the capacity as the chairman of Oracle Health since that acquisition. And it's been a really fun ride.
And so can you share with us, what are you most excited about now that you're part of Oracle Health? And I know that your whole career has been focused on bridging the gap between technology and healthcare. So this will seem like a great fit for you.
Well, yeah, I think that there's two things that I'm most excited about. So I'm going to have trouble answering one.
Okay.
The first one is we now have the resources to make it so the doctor or the nurse can see the patient and never touch the terminal. So instead of, it took us 40 years to digitize the record.
Right.
It's great because if I think about it, during COVID, we never had a pharmacy that misread the prescription like you and I remember from the old days. Mm-hmm. We never said, Mr. Smith's chart's unavailable because Dr. Jones took it home over the weekend. So we shouldn't be too mad at the electronic health record because it digitized it.
Right.
But it also created a lot of workflow issues. It really turned what I would say is healers into data clerks. Mm-hmm. And we've now fixed that. So we're really excited about our new electronic health record, which allows you to see a complicated patient in an outpatient setting, and using AI, it captures a summary like a good med student would for the patient. You go in the room with the patient's permission. The ambient listening captures everything that's happening in the visit. You can even in the middle of it interrupt and say, hey, Oracle, what are these patients' hemoglobin A1C? So you can kind of interact with the record using your voice. And then the magic, when you're all done, the note's done, the coding's done, the prescription's done, the scheduling of a patient is done, the follow-ups, the labs, et cetera. So think of it as you never take your eyes off the patient, or nursing. You never really have to go look for supplies and things like that. So that's one thing that, for those practicing clinicians out there, it's game changing to where folks are saying, I was going to retire and now I'm not going to. I mean, it's that powerful.
Wow.
And then the other thing that Oracle has brought to it is a much broader sense of how we can create an open and connected platform. What do we mean by that? In every other industry, that system of record, that in our case, the electronic health record, is connected to back office technology, but it isn't in healthcare. And what does that mean? Well, Oracle is a leader in human capital management software, ERP, budgeting software, supply chain, cloud. Well, what does that mean in healthcare? Well, in healthcare, when a nurse is giving chemo for the first time, now the nurse has been certified on it, but that was 2 years ago. And now that nurse is about to hang chemo for this patient. It has never done it in a real patient before. Well, we should know that from human capital management, and just-in-time training should come up right in the electronic health record. Or when I'm done with my procedure in the operating room, and voice helps me with my note and all those things, that should also drive supply chain. It should also, at a higher level, understand that we're doing a campaign because we're behind on breast cancer screenings. Do we have enough people? How's the staffing? How's it going to play out? So connecting those pieces, I think is incredibly powerful. And it's the only industry where it really hasn't yet been done. And Oracle's been successful in so many industries in doing it. And so when you ask me what I'm most excited about, yeah, I'm really happy to take the pain away from the docs and nurses and speech pathologists, et cetera, and pharmacists and front desk people who are interacting with this electronic health record. But I'm also happy because I think the real power is then allowing care to just be more equitable, more patient-centered, higher quality and lower cost. And this tech backbone, I think, can really do that.
So data sets don't always reflect the population, the demographics of the population. So what are some things we can do to fix that?
Yeah, so it's absolutely crucial to do that, to get tools that then can be used on the whole population, right? So I mean, that's just fundamental.
Yes.
So here's how we're approaching it. So Cerner, now Oracle, is the largest electronic health record company in the world. And when we're done with our VA rollout, we'll again be the largest in the United States. We've been successful in multiple markets. So we talk about the international market, we do really well. We talk about the small community hospitals like Nashville General, we do well. We talk about the for-profits like the tenants, we do well. In the federal space, the VA, Department of Defense. So having those community hospitals, rural America, our customers have signed up to be part of our Learning Health Network, which basically we say to our customers, and now I'm talking US-based, hey, give us all your data, de-identified, and you have access to all the de-identified data, and you can do research with it, and we can also use it to build models and train things. Well, our database in the United States has 3 times the diversity of any database that's that large anywhere. And that's because we've done so well I'm in California right now, at San Joaquin Hospital, which is a small kind of farming hospital, or Osmond, Nebraska. I think the Osmond population is 800, right? So we have all the different pieces of healthcare, now I'm talking in America, that allows us to make sure our data is diverse and representative. It does something else that's really important. So that's helpful from an AI standpoint. But from a life sciences standpoint, we also say to that learning health network of ours, hey, do you want to be part of a study? So now we have folks that are participating in study, and of our 100+ health systems that are part of this, 50% of them are research naive. These are people that have never participated in trials. And now they're bringing in folks to trials that never would have got it because they don't go to medical centers. And then when you talk about the commercialization, now let's say some new diagnostic or medication is found, the docs in rural America and small town America were part of the trials, and we'll start using that, and it won't take us 17 years to get from the academic center to the rest, to Main Street. So we think our superpower from a life sciences standpoint is we've created the most diverse learning network there is in the United States.
Well, it is amazing, and I think the things you can do are going to be quite amazing as well. But one of the things that I think about is, given these amazing technologies and what we can do, Should we think about how we train medical doctors in the future in the context of all this excitement about technology?
I think that that's something that we've never been good at in medical education, right? We really have an apprentice model. This is how I did it, and
Yes.
then you train someone, right? Our education in healthcare has not, I think with problem-based learning, we've seen some advancements, but we really now need to make an advancement. So a few things are going to happen that we spend a lot of time teaching that we no longer need to teach. So one of the things we teach medical students is go learn everything about your patient. Well, I can do that with AI in about 10 seconds, and I can do it better than the med student. So to pull records from multiple sources, to make a longitudinal record, to deduplicate it, and come up with a very reasonable differential diagnosis on a patient, the computer's really good at. The other thing it's good at is documentation. So we think about these medical student notes. Well, I can do a med student note with AI that's I'm certain has less errors and is more accurate. So what I think is really important for your students and future students is this human-computer interface. So what are the right prompts to get me the right information? How do I use, as we just spoke about, these very powerful tools in a way that promotes care and does not exacerbate bias? And do I understand how these models were made and where, when I should use them? Now, I don't think medical students need to know how to code, but I think they certainly need to know how to interact. I get often asked, do you think AI is going to replace doctors? And I say AI is not going to replace radiologists, but radiologists that do not embrace AI will be replaced.
Yes.
So our students, and actually that's something we're excited to do with you,
Yes.
need to really understand how to interact with this powerful technology. It's now at our fingertips.
I totally agree. And I think that the amount of time it takes to train a physician could conceivably be reduced by what you just explained. When I was in medical school in the early 80s, we had to memorize telephone books. And, a year or two later, half of what we learned turned out not to be correct. So I really think that your approach is the right one. So with all the advanced technologies and all the possibilities that are in front of you and Oracle, is there something in particular you're focusing on now that is of particular interest or exciting to you?
The thing that really drives me is, can we make healthcare more accessible and understandable and equitable? And using data, I think we have a real opportunity to make some fundamental changes. First of all, I think it will decrease the cost and the waste and the misdiagnosis, which is great, because if we spend less on healthcare, that will give us more opportunity to, build roads and schools,
right,
and increase wages. So of course, it would be great to spend less total on healthcare. But the thing that really drives me is pretty much any urban center in the United States, and this is true outside the US. And if you're 2 subway stops or a couple bus stops or across the freeway or over the river, you see folks' life expectancy varying by 20 to 25 years.
Yes.
And they could all be going to the same doctor and nurse. So I can make the doctor and nurse and hospital as good as I want, but that doesn't really decrease that gap. And the way to really get at that gap is to really understand that in that part of town, we don't have great access to food. There's a lot of stress because the neighborhood's not walkable. There's transportation issues. There's education issues. There's water issues. There's issues around what's running off from antibiotics in the farms, right? And so there's these, what we broadly talk about as these social issues that are not only decreasing the years in your life, but the life in your years. And the more we're able to show that and then try interventions that get at it, the better chance I think we have of really making it so everyone has that opportunity. And I think we can be a huge part of that. I do not think it is a tech fix. I think it is a technology fix in partnership with folks who are in and of that community and providing care to those people. But we and I want to make sure we're doing everything we can to give them the right information at the right time and the right way to kind of have this cycle keep going so you can understand and iterate and get better and better.
Well, I totally agree with you. And even here in Nashville, there are zip codes. If you compare them, the life expectancy differences are astounding, at least to me. And those social determinants are certainly something you have to be focused on. And in our new school of global health, we're going to be focused on the political determinants of health, which are also really important in this day and age that we live in. But how can technology empower those individuals who are trying to address the social determinants of health?
Yeah, so let me give you an example. So when you even go back to this term burn, where doctors say they're burned out, it's now believed they're burned out because we make you do too much time in the electronic health record and you got to fill out forms. That's actually not where the term came from. The term came from, I'm a doc in the ER and the patient comes in with an infected heart valve from IV drug abuse, and we go upstairs, we do 3 weeks of antibiotics. The patient's sepsis is cleared, we send them home, and 2 weeks later, they're back in the ER with an infected heart valve. And there's this moral, you're just beaten up because you don't have the right tools to actually care for that patient, right? You got antibiotics, but really what you need is, substance abuse treatment in the community, and you probably need to go even further upstream. And right, so that's where the burnout came from. So let's talk about where technology can play a role. So you're about to see a new patient or a follow-up patient. Let's talk about a patient of yours that has diabetes and is coming in post-pneumonia for a checkup, for a follow-up. Well, with the AI, not only do we say this is a 52-year-old woman who's here post-pneumonia with type 2 diabetes, we pull in data from literally thousands of sources. So not only multiple EHRs, but social determining data sets that tells you this person is likely also food insecure. So you literally walk in the room, you got 3 sentences, it's kind of the prep for the patient. Think of it as a great med student summary. And it's captured some very important social information. Okay, so in the visit, you're not at the computer, you're talking to the patient, you listen to the lungs, it got better. You can't remember the hemoglobin A1C, you asked for it, looks like it's gone up. So I think we should increase the metformin. But you know what, let's talk about your food issues. Are there times this month where you've run out of food, or there's times this month where you thought you didn't have enough money for food? And the patient says, yeah, there is. There's times where we need to, really, I'm nervous about it and I buy non-nutritious, high caloric food because I'm hungry or my family's hungry, and as opposed to the healthy food that I know I should buy because, $5 of blueberries and then you get them home and they're moldy is not a good play. So we bring you that information. And then in the action part of the visit, the patient's automatically enrolled in a food prescription program. So when you think about that, it's not like docs would ever say that's the wrong thing to do. But the current system is so burdensome that I don't even want to ask that question. Because if I ask that question and you say yes, it's going to take us a long time to figure out what's going on. And then I don't even know where to send you. I got to find the social worker. I think we just laid off a bunch of social workers. I don't know what to do with that information. So don't tell me anything. Let me just get through my note. Let me increase your metformin. So we brought in that social determinant in workflow in a way that would make your work easier. And obviously it's better for the patient. So that technology kind of arc, we think is very important in driving better outcomes, in that case for a patient. Now we can take it at a higher level and we could look, we call it our health data intelligence, but we could look at a population level of information and say, here's the food desert, or here's the area where it looks like we have lower vaccination rates. And not only that, if we're going to do an outreach or a campaign, do we have the right resources and the right staffing to do that campaign in that region? So whether it's at a patient level, a community level, we also deal with, countries at a country level. Can we help you tackle those things that are driving, that zip code and genetic code are driving more health outcomes than your doc or your nurse?
So, we at Meharry are very excited that Oracle is coming to Nashville, and we're very excited to partner with you to try to create a system to engage the unengageable when it comes to providing healthcare. But Can you just tell us about the decision to come to Nashville? What was involved in that?
Nashville feels like it is the healthcare city for America. And we're really excited. And for me, as a healthcare person, to be in Nashville, there's a lot going on there. People are collaborative. There's a lot of the big players there.
Yes.
So it's sort of a dream come true.
Well, I appreciate that.
The only thing, though, James, is we don't know what'll be in the lobby. So I said we got the sailboat. We got, I don't know what else we're going to sponsor. Maybe some kind of country music
Okay,
thing.
all right.
Garth Brooks statue.
Okay. Well, I'd like to close by asking you, from your perspective, what are some of the steps that healthcare companies writ large could take to make sure there's meaningful, lasting change in how healthcare is provided to the people of the United States?
Yeah. So I think the first thing is to enter this with humility. I think if you look at especially from the tech world, the big swings that people have taken that have not kind of yielded a lot, it's because there's been lack of humility. There's almost a sense of, hey, you healthcare people, just use this app. We know how to fix banking. You guys should use this. And the reality is, healthcare is a very high stakes business. Is very people driven. There's a lot of history. There's a lot of ecosystem that's working against you for a lot of various reasons, oftentimes the finances. And then the second is healthcare doesn't need another point solution. Healthcare needs a whole new way of doing it. And who is big enough to say, I'm going to take it on end to end? And that's actually what we're trying to do. But when we do that, or we say that, the next thing we say right away is, but we don't want to do it alone. Right? We want to go end to end. We want to do it with partners, and we want to enter with humility. So that's what's driving us. That's why we're excited about our relationship with you. We see that as, obviously representing Nashville, representing, oftentimes the underserved, representing kind of the future of healthcare healers. And we want to do that at scale. But the way to do it is to build those trusted relationships. I mean, fundamentally, I say healthcare is people caring for people, and it's built on trust. And so we have to come in and understand this is a people business. We are simply the technology provider that allows those people to provide better care. And that could be, caring for myself at home, caring for others in the community. It could be more, in the brick and mortar care, but it's still people taking care of people, and you got to trust them.
Absolutely. David, thank you so much. I really enjoyed the conversation.
My pleasure. Thank you.
Thanks for listening to Public Service Announcement. To follow along on the rest of our journey, visit www.mmc.edu. And please remember to follow, rate, and review this show wherever you get your podcasts.